Good evening, my name is Courtney Koenig with Empire Surgical, and tonight we're going to discuss a rotator cuff repair. For argument's sake, I'm going to be doing a double row rotator cuff repair using helix on the medial row as well as a Versalock on the lateral row. First thing I want to talk about is the preparation of doing a basic rotator cuff repair. From there, I will move into the more specifics of using a helix on the medial row and using a Versalock on the lateral row. First, let's talk about the basics. We're going to need 3 portals when doing a rotator cuff repair. Now, a lot of the stuff I'm going to say is surgeon dependent, but for argument's sake, we're going to just go with the basics and just know that a lot of this stuff can vary depending on surgeon or preference. So 3 portals. First portal we want to talk about is the viewing portal, also posterior located. It's going to be 2 centimeters medial and 2 centimeters inferior to the acromion. It's a soft indention on the posterior side of the shoulder joint. Second portal is going to be the working portal, also known as the anterior portal. And the third is the utility portal. This will be located on the lateral side of the shoulder. Now don't forget, the utility and the working portal are interchangeable. You're going to be doing some work in the utility portal, you're also going to be using the working portal as a utility portal once in a while. But for argument's sake, once again, I will continue to use the anterior portal as the working portal when I'm talking about it, and I will use the lateral portal as the utility portal throughout the video. Now that all 3 portals have been situated by the surgeon, we're going to go in and reconfirm the rotator cuff damage. We're going to do a general diagnostic of the shoulder, starting in the glenohumeral joint. We're going to put in the scope into the viewing portal, or the posterior portal, and just make sure, using a probe in the working portal, that there is rotator cuff damage. Now, when looking in the glenohumeral joint, the rotator cuff will be on the superior portion of the scope. We will probe around, make sure that it's tear. If it is torn, we will make a little mark to indicate where it is for when we go into the subacromial joint space, which we're going to do after looking at the glenohumeral joint. Now that we're in the subacromial joint space, we will reconfirm that we have a rotator cuff tear. The most common rotator cuff tears are going to be a crescent or U-shaped tear, as well as an L-shaped or L&L shaped tear. Now that we know we have a rotator cuff tear, we must prep the area for the rest of the procedure. We will need a tissue liberator that's found in the shoulder tray to liberate or separate the rotator cuff from any damage that may have occurred when the shoulder joint was compensating for the tear. For example, scar tissue. We want to separate or liberate the rotator cuff from any scar tissue or damage that is in the joint space. After we have the rotator cuff liberated or separated, we're going to go ahead and create a bloody bed on top of the humeral head, or more specifically, the articular margin, as well as the greater tuberosity. We're going to use a rasp, also found in the shoulder tray, to manually create a bloody bed. This bloody bed will aid in healing after the procedure is done, therefore giving us a higher success rate of rotator cuff repair. Now that the shoulder joint is prepped and ready to go, we are able to start the procedure using helix. Helix comes in BR, bioalkyl rapide, which is bioabsorbable or body absorbable. It also comes in TI, which is a titanium, and also comes in PEEK, polyethylethyl ketone. All 3 of these come in 4-5, 5-5, and 6-5, depending on the strength of the bone in the shoulder joint. For argument's sake, I will probably refer to using the 5-5 throughout the video. Now that we have decided to use the PEEK anchor at the size of 5'5", we are ready to decide where to implant the anchor. Like I said, there's many different ways to do this. For argument's sake today, we're going to use a spine needle to locate the best position on top of the articular margin that will give us the best angle, which is going to be 45 degrees, or dead man's angle, to be able to hold down the rotator cuff on top of the articular margin and wrap around over to the greater tuberosity. For instance, if we look at it like this is the damage. We want to drop it in the middle on the articular margin. Therefore, we can have the equal spreading out of the sutures to grab and to pull over to the greater tuberosity. There's different ways to insert the anchor. For this video, I'm going to use the universal awl. Universal awl will go through the percutaneous hole on the superior part of the shoulder joint. We will awl in the size of desired. In this case, we're going to use 5.5. After the awl has created the hole for the anchor, we will remove the awl and insert the anchor into percutaneously through the hole. It's going to come with 10 strands, 5 for the calcaneus part of the bone, and 5 for the cornicus layer of the bone. The small threads are going to go deeper down, giving it a stronger tension within the bone. The thicker threads are going to be in the harder part of the bone, the more brittle part, and spread it out as well as increase the strength of the anchor. Now we're using a double-loaded helix, so the double-loaded helix is going to have 4 strands. It's going to have 2 strands sticking out the top, both of which will be blue, and then 2 more strands sticking out the top, both of which will be purple. So we have the blue strands and the purple strands. It's going to get confusing, so we want to make sure we have great detail in our suture management. We're going to be calling them blue 1 and blue 2, purple 1 and purple 2. Now that we have purple and blue 1 and 2 sticking through the percutaneous incision on top of the shoulder, we will grab a crab claw from the shoulder tray, and going through the working portal, we will feed all 4 sutures through the working portal. We want to get them out of the way as well as get them into the joint space for the steps ahead. Now that all 4 sutures are through the anterior portal, we will enter through the utility or lateral portal with the espresso, passing each suture through the rotator cuff one at a time. This is so we can do a mattress stitch compared to a single stitch. If we were doing a single stitch, we would send one side of the suture through and just tie down. For this procedure, we're going to do mattress stitch, so we're going to set purple 1 and then purple 2, tie them together, and then add those to the Versalock, which I'll get to later on. So like I said, using the crab claw, we're going to grab purple 1, pass it into the joint space through the anterior portal, out the utility or the lateral portal. We're going to insert it into the espresso, tail down. The espresso is going to be a passing needle that's going to insert a needle 14 millimeters medial into the rotator cuff and pass the suture through the superior portion of the rotator cuff. We're going to repeat this 4 times. After we pass one through, we're going to take it back out the anterior portal and clamp it to the patient drape to make sure we keep tension as well as keep them all in order. We want to work from purple 1, purple 2, blue 1, blue 2, for example. However you want to do it, it's all surgeon dependent. got to make sure you keep a specific order that you learn to continue to replicate throughout all surgeries. It's very confusing if all these sutures get loose, start to get tangled, start to make a mess. You want to keep tension and keep them in order. Purple 1, purple 2, blue 1, blue 2. Nice in order. Since we're viewing in the posterior portal, the viewing portal, we are going to want to pass our sutures from the anterior portion of the tear to the posterior portion of the tear. This will allow for greater visibility when working and passing all of these sutures. Now that all 4 sutures are passed, we're going to want to tie down these sutures. Tying them down, we're going to work the other way. We're going to work from the posterior part of the tear, tying to the anterior portion of the rotator cuff tear. This as well will increase visibility, as well as keep these sutures in nice, consistent order. Now that we have all 4 sutures passed through the rotator cuff, and the purples tied together and the blues tied together, we are ready for the VersaLock. All 4 of these helix, anchors, and sutures have been placed on the medial row, which is on the articular margin, like I said earlier. Now the VersaLock will go on the lateral row. Obviously, it's going to be lateral to the articular margin. It's going to be on the greater tuberosity. From here, we're going to increase the amount of contact the labral repair has on the bloody bed we created, as well as trying to get to the anatomical original status of the rotator cuff. The VersaLock is going to be another sort of anchor from MyTech that's going to feed all 4 of the suture strands that are hanging out of the helix down together, creating a mattress stitch hanging over the rotator cuff. We have all 4 sutures out the anterior portal, placed in order, 1, 2, 3, 4. They've been tied together. We did not cut them. We left them the way they are. Now we're going to pass them all back into the joint, back out the lateral portal, and into the VersaLock. The VersaLock is going to come with a butterfly-shaped device, marked left and right. And when looking at the lateral view of the shoulder, it will be like such. With these strands hanging out, we're going to pass 1 of each, for instance, purple 1 and blue 1 into the left side, and purple 2 and blue 2 into the right side. This will create a crisscrossing motion to hold down the rotator cuff. Once again, we want to increase the contact of the bloody bed and the rotator cuff to improve healing, as well as increase the chance of getting the anatomical correct location. After we pass all 4 sutures through the butterfly, you will just simply pull down, and all 4 sutures will be threaded into the VersaLock anchor. From here, we're going to cinch the VersaLock anchor into the lateral portal to the greater tuberosity or point of insertion on the greater tuberosity that we would like to have. We're going to use the mallet and mallet the VersaLock into the shoulder. After it is in place, we will use the VersaLock gun to load the sutures, crank to increase the tension on all of the sutures, and we will fire, releasing the anchor into the greater tuberosity, or the lateral row now, and releasing all 4 sutures into the lateral portal. From there, we will go in and cut all 4 sutures, and we are done with our lateral and our medial rows. So once again, we did a double row rotator cuff repair using a medial row and a lateral row. We also used a double stranded or double loaded helix, which provided 4 sutures out of 1 anchor to increase the coverage of the rotator cuff on top of the humeral head or the bloody bed that was created by the rasp. And we used the VersaLock to hold all 4 of these sutures in place, holding the flap down onto the greater tuberosity. Close up the portals and the process is complete. I hope you enjoyed the rotator cuff repair using the double loaded helix as well as the VersaLock from DePuy MyTech. Thank you very much. You have a great night. Thank you.